The pre-session, the triadic relationship. Basically, an interpreter must navigate the dynamics between the provider and the patient, ensure messages are accurately conveyed in both source and the target languages, remain unbiased, and facilitate communication effectively. In a triad of three individuals, there's often one person who may feel excluded, and the interpreter frequently bears the pressure of occupying a middle position. Since they are confident and proficient in both languages, both the patient and the provider turn to the interpreter for communication. Interpreters need to recognize this dynamic and strive to manage the balance and establishing the appropriate spatial setup. As highlighted in the book, The Art of Medical Interpretation, interpreters are expected to blend the sensitivity of an artist, the objectivity of a scientist, and the compassion of a therapist. It's crucial to foster an environment where the provider, the patient, the interpreter are all equally valued. And understanding the dynamics of this triadic relationship entails maintaining neutrality and avoiding favoritism towards either party. Seating arrangements. Seating arrangements are crucial for maintaining balance during a session. Traditionally, many interpreter training materials advise having the interpreter sit behind the patient or the provider to minimize their visibility and avoid drawing attention to themselves. While this idea aims for the interpreter to be as unobtrusive as possible, it's important to recognize that many people feel uncomfortable with someone positioned behind them. Consequently, interpreters face the challenge of arranging seating in a way that ideally forms a triangle, allowing for proper eye contact between the patient, the provider, and the interpreter. This ensures that no one feels excluded. In practice, however, most locations and rooms do not have the space or number of chairs necessary to create this ideal triangle setup. Often, examination rooms are so cramped that only the patient can sit, while the provider and the interpreter may need to stand during the session. It's important to remember the principle of maintaining a triangle, though. In such a confined spaces, an interpreter should avoid sitting on the examination table or holding a child in their lap. As the session unfolds, it's common for the provider and patient to develop the tendency to look only at the interpreter rather than directing the parties to interact directly with each other. The interpreter can subtly adjust the chair or their standing position to enhance eye contact between the patient and the provider throughout the session. Can you think of a discreet way to encourage communication between providers and patients? One method is for the interpreter to briefly look down while conveying messages and gesture to direct attention to the appropriate person. If eye contact is culturally inappropriate or during sensitive discussions, the interpreter can turn away from the patient during the examination and explain that they are listening and not watching. Alternatively, the interpreter can ask if they should step outside to interpret from the hallway. If the patient and the provider focus only on the interpreter might look down or adjust their chair to facilitate direct interaction between them. Can you think of a discreet way to encourage communication between providers and patients? One approach to managing eye contact involves the interpreter looking down briefly while conveying the message. At the same time, The interpreter can gently gesture in a semicircle, directing attention toward the person with whom eye contact should be made. When eye contact is culturally or religiously inappropriate or during sensitive discussions, and the patient is looking down, the interpreter can create an imaginary barrier. For example, during physical examinations that involve checking genitals, the interpreter can turn away from the patient, facing the wall, and explain that they are listening attentively and not watching the examination. Another option is to ask both the patient and the provider if they would prefer the interpreter to step outside the room. The interpreter can then interpret from just outside the door if necessary. If the patient and the provider are only looking at the interpreter can choose to look down or adjust their chair slightly to maintain focus between the patient and the provider. According to the interpreter standards, it is acceptable to remind the patient to look directly at the provider during the session. However, it is important to use a gentle tone of voice when giving this instruction. The role of the interpreter at the start of the medical encounter can create unnecessary interruptions and increase tensions. We have received numerous reports from interpreters in the field indicating that healthcare providers often feel frustrated when given guidance, especially when they are already overwhelmed by their inability to communicate in the patient's language. Whenever possible, interpreters should encourage eye contact with the provider during the pre-session. They play a crucial role in fostering a natural alliance, which improves the overall dynamic between the provider and the patient through effective body language and communication. Interpreters begin the session by introducing themselves and fostering appropriate eye contact between the provider and the patient, clarifying how the interpreting will proceed considering the patient language level, setting up physical space for the session, and fourth, emphasizing the importance of confidentiality, completeness, rhythm, and grammatical person. Let's focus now on this fourth aspect of the pre-session. First, confidentiality. The interpreter should inform both the patient and the provider that all the information exchanged during the session will remain confidential among those present. The session is considered to start with the first interaction between the interpreter and the patient, which often occurs in the clinic or the hospital waiting area. Many interpreters have gained experience over the years without formal training. Frequently, these interpreters tend to use the third person instead of the first person, which can lead to longer, less direct communication. This often creates the impression that the interpreter is untrained and lacks professionalism. Now, let's talk about the E. Everything you say will be interpreted. Every piece of information, whether shared in the waiting area, during the session, or afterward, must be interpreted. Interpreters cannot keep any information confidential from the patients or the providers. Let's talk about the R. Rhythm or the flow. The smooth progression of the session is vital to its effectiveness. At times, an interpreter may need to request that either the provider or the patient slow down their speech. During the pre-session, the interpreter might agree on a specific stop sign or hand signal for indicating when it's necessary for someone to slow down. Let's talk about the P. Personalization. The interpreter will ensure or rather, the interpreter will assume the form of the speaker by using the first person. In most interpreting scenarios, the interpreter utilizes the first person. Consequently, when a patient or provider states, "I have to go," or "I have a headache," the interpreter will convey the same person, "I have to go," or "I have a headache," instead of saying "he has to go," or "he has a headache." Maintaining the first person is vital to the effectiveness of the interpretation. So as we saw, those were 4 different acronyms: CERP, confidentiality, E for everything, R for rhythm, and P for grammatical person, the first person. The acronym CERP will guide the session if the interpreter ensures that all parties understand its purpose. CERP or CERP should be done with the patient and the provider, whether they are together or apart, and it should be done as soon as the opportunity presents itself. Later on, we're going to talk about how that's a protection for the interpreter. The waiting room typically serves as the best location to explain CERP principles to the patient, while the provider might receive a brief summary just before the sessions begin. Interpreters have observed that some healthcare providers seem too busy to discuss CERP. In some instances, providers may enter a session and start the medical interview without acknowledging or greeting the interpreter. In such cases, the interpreter may quickly interpret the initial words spoken by the provider and then interrupt by saying something like, "Hello, my name is so-and-so, and I will be the such and such language interpreter for so-and-so patient. Please allow me a moment to explain how an interpretation session works." This explanation of CERP can typically be completed in under 40 seconds if the provider is in a hurry. Now let's discuss some challenges in interpretation. Accuracy and completeness are crucial for the professional interpreter. Accuracy involves understanding the message in its entirety and conveying it in the same manner as the speaker intended. This does not mean translating word for word, but rather providing a faithful representation of the message's meaning. Achieving accuracy requires staying as close as possible to what was said without altering the speaker's tone or register. If the interpreter relies solely on a direct translation of each word, the true meaning of the message is likely to be lost. Interpreters who focus too much on finding the exact words may become so concerned with literal translation that they neglect the overall meaning. This can lead to interpretations that resemble mechanical outputs, losing both completeness and accuracy. When interpretation is limited to words only, there's a risk of misunderstanding and misrepresentation. The most effective and accurate interpretation is not necessarily a verbatim, word for word reproduction, but rather a thoughtful understanding and transformation of the message. The interpreters who become overly fixated on finding specific words, they can become mentally distracted, which compromises the integrity of the message. Let's discuss errors in interpretation and aiming for 100% accuracy. Medical interpreters have a responsibility to themselves, patients, providers, and their community to ensure accuracy in their interpretations. Achieving accuracy in consecutive interpretation is not an easy skill to master. While striving for precise interpretation, interpreters must not only focus on converting words from one language to another, but also ensure that the speaker's original meaning is preserved. Even interpreters who are fluent in both English and the target language can encounter challenges with accuracy. For instance, an interpreter who has lived in this country for over 5 years may understand the vocabulary essential to accurately interpret immigrant life. However, the same interpreter might mistakenly convert a variety of common words and phrases incorrectly. This issue is often referred to as false fluency. False fluency primarily arises when an interpreter uses terms in a way that is not found in any textbook. I refer to this as immigrant language. For example, I sometimes say in Portuguese that the tráfico, traffic, is quite bad today. However, the word tráfico actually refers to a type of business exchange, not the volume of cars on the road. The proper term for traffic in Portuguese is trânsito. Interestingly, it has been my experience that fellow interpreter immigrants rarely correct me, while only visitors from Portugal tend to notice my mistake. Examples of immigrant language include terms like appointment, follow-up, and checkup. It's common for interpreters to adapt these words into their target language by simply modifying the accent rather than changing the terms themselves. While a patient with a similar background to that of the interpreter may easily understand these anglicisms, they can be confusing for newly arrived immigrants. Interpreters should avoid Americanizing their use of the target language and strive to ensure that their interpretations remain true to the original meaning. Recently, in an interpreting class, one student performed well during the first role play, but she made one notable error. When the patient mentioned having a funny voice or sore throat, the student interpreted funny in a way that suggested comic humor, as if it were about a joke. However, the patient meant that his voice sounded unusual or abnormal. The student, a new interpreter who was nervous during the role play, focused too much on the word translation and as a result distorted the actual meaning of the term. Another common interpreting error occurs with idiomatic expressions that are specific to certain countries or regions. These expressions can be ambiguous, so interpreters need to ask the speaker for clarification to ensure that they understand the intended meaning and provide an accurate interpretation. The following examples illustrate the potential pitfalls when interpreters are unfamiliar with idiomatic expressions. An adolescent boy during a session with his mother screams, "Get off my back!" The interpreter translates this literally, but misses the intended meaning of "do not bother me" or "leave me alone." Later, the same boy refers to his teacher as a pain in the neck. Again, the interpreter interprets this literally, taking it as a statement having to do with the boy's body parts, his neck, when the intended meaning has nothing to do with his body. Instead of understanding the correct meaning, which is, "This teacher is always bothering me." In the in the emergency room, an agitated young woman whose family member has died in a car crash tells the attending physician, "I have paid my dues. I do not deserve this now." The interpreter mistakenly renders her message as, "I have paid the money," rather than capturing the true statement, which is, "I have more than made up for my wrongdoings." A healthcare provider, frustrated with the patient's ongoing insistence on completing an insurance questionnaire, exclaimed, "I have bent over backwards for you, and still you're not satisfied. You can't expect me to bear the brunt of your insurance not wanting to pay for treatment." Unfortunately, the interpreter miscommunicated this message by interpreting the phrase "bending over backwards" literally, and suggesting that the provider carries responsibilities rather than accurately conveying, "I have done all that I can and I cannot take responsibility." In addition to being familiar with idiomatic expressions, interpreters must also develop a solid understanding of the human anatomy and common illnesses. For example, a common interpretation error involves confusing or mistaking terms such as gallbladder and bladder, spleen and liver, or angina, a type of chest pain, with a heart attack. Additionally, interpreters might refer to strep throat as a simple infection, overlooking its potential complications. If untreated with antibiotics, strep throat can lead to serious health issues like rheumatic fever, which are far more serious than those typically associated with average throat infections. Do patients always receive the correct message from their interpreters? Glenn Flores and others, in their article "Errors in Medical Interpretation and Their Potential Clinical Consequences in Pediatric Encounters," conducted research to determine the frequency, categories, and possible clinical consequences of errors in medical interpretation. The research found on average 31 errors per session, with over half, that's 60%, of these errors having the potential for serious medical consequences. It's concerning that the study combined professional interpreters with bilingual providers whom it treated as interpreters, yet the number of errors remain alarming. The research found an average of 31 errors per session, with over half, that is 60%, of these errors having the potential for serious medical consequences. Although the study combined professional interpreters with bilingual providers, whom it treated as interpreters, the number of errors remains alarming. The most common types of errors identified were omissions, false fluency, substitutions, editorializations, and additions. In this section, interpreters learn about 3 primary impediments to memory: emotional, mechanical, and physical blockers. Let's consider a brief example of each type of potential memory block an interpreter might encounter. Imagine interpreting for a young child with a knee laceration. The child is bleeding and crying out in pain, which could easily cause the interpreter to become emotionally absorbed in the situation. The emotional involvement might lead the interpreter to pause or even halt the interpretation, obstructing the flow of communication. As a result, the healthcare provider may have to repeat words or phrases. Emotional blockers like this can hinder the interpreter's ability to perform effectively. However, in this particular case, the provider was aware of the interpreter's silence, which is fortunate, as it is less likely that a provider would notice omissions that occur while the interpreter is actively speaking. On the other hand, mechanical blockers can occur when an interpreter misfiles or assesses the wrong information, resulting in inaccurate interpretations. For instance, during medical training, an interpreter might mistakenly assume that the bladder and the gallbladder are the same organ. If this interpreter later uses both terms interchangeably in a subsequent interpreting session, it could have serious potential and even tragic consequences. Physical blockers are common challenges in medical interpretations. For instance, an interpreter suffering from severe allergies might take antihistamines, which can lead to drowsiness and impaired cognitive function. In a session with an alcoholic patient, the provider may ask how often the patient drinks, while the patient might respond with only 1 glass per meal. The interpreter could mistakenly say 1 glass per day. In this scenario, the interpreter has inadvertently omitted the crucial word only and incorrectly substituted meal with day, resulting in a significant miscommunication. In summary, interpreters play a critical role, and their interpretations can have profound effects on both the lives of patients and their own professional careers. We strongly encourage all medical interpreters to participate in ongoing training and to stay current with latest techniques for achieving mastery in the field and strive for 100% accuracy. Let's now discuss the different roles of the interpreter, starting with conduit. This is the most recommended role for medical interpreters. In this role, the interpreter listens to the speaker, understands the information, conveys it accurately, and maintains the speaker's tone and style. Think of the interpreter as a bridge, communicating by adhering closely to the original content and wording. Imagine carrying a large bag filled with information that belongs to someone else. You're simply the messenger or transporter. On one side of the bridge, you gather all the information, both content and words, and close the bag. When you cross to the other side, you open the bag and let the information flow out in the appropriate target language. It's essential to remember that you do not open the bag while crossing, nor do you add or remove any information. The goal is to keep the information as pure as possible. Clarifier. The role of the clarifier is the second most prevalent function of the interpreter, describing someone who's always prepared to adapt to any spoken style to create a linguistic equivalent and who poses questions to better understand the true meaning behind the speaker's ambiguous terms or phrases. For example, in the United States, the phrase special education can carry significant cultural implications. While interpreters might be able to translate the words special and education, they may struggle to convey the term's true meaning. In such cases, the interpreter must notify both parties of the necessity for clarification so that the accurate meaning of this term can be conveyed precisely. Culture broker. This term refers to the function an interpreter fulfills when they recognize potential miscommunications between a patient and a healthcare provider. For instance, during a mental health status evaluation, to assess whether the patient is oriented as to time, place, and person, a patient might respond with, "I live in a blue house close to the old tire factory." If the interpreter does not intervene, there is a risk that the provider will quickly conclude that the patient is disoriented regarding their location. In this situation, the interpreter should make the provider aware if this type of description is typical for individuals from a specific age group or immigrant background. The interpreter might also recommend an alternative approach to the provider so that he or she can assess the patient's orientation concerning place. In any cultural broken situation, the interpreter must ensure that they do not express personal opinions as facts and should always introduce any suggestions with a polite remark such as, "It may not be the case in this situation, but in the interpreter's experience, this type of reaction is often seen among members of a certain community. Perhaps you could verify this with the patient." You might start your comment to the provider with phrases like, "It seems to the interpreter," or "the interpreter has noticed," then let the provider follow up with additional questions to the patient to make sure that they are getting accurate information. The advocate. In this capacity, the interpreter will advocate for another individual, typically the patient. This role can pose challenges for the interpreter. While they may assume this role, it's advisable to first review the policies of the hiring organization. Some institutions do require their interpreters to act as advocates for patients. So keep in mind, you can support a cause without causing conflict. Maintain professionalism. Fortunately, in the majority of instances, medical interpreters are not required to serve as advocates, but instead should communicate their concerns to a supervisor who has the power to implement changes if needed. The sense of frustration and helplessness that can stem from being unable to affect change immediately is amongst the hardest challenges to endure. On the positive side, being distanced from this uncomfortable situation allows the interpreter to focus solely on the spoken information, facilitating a more accurate interpretation. Clearly, it is preferable for interpreters to maintain their roles as conduits with occasional shifts into the roles of clarifier and cultural broker. The introduction of the IMIA Medical Interpreting Standards of Practice of 1996 elevated the standards of professionalism in medical interpreting, leading to their widespread implementation. These standards now significantly impact practices across the nation due to the actions of numerous trained medical interpreters. For example, well-trained interpreters who are well-versed in the standards will decline any tips or valuable gifts given in connection with a triadic interaction. They refrain from offering opinions on treatment or commenting on a provider's credentials. They uphold the patient's confidentiality by not disclosing private information to community members, relatives, or friends. They aim to ensure completeness, accuracy in their interpretations while adhering to the speaker's language register to present all information in its most authentic form. Furthermore, they are dedicated to self-evaluating their interpreting performance and making necessary corrections. Nevertheless, when well-trained interpreters face challenges regarding the ethics of shifting between various roles of the medical interpreter, conduit, clarifier, cultural broker, and patient advocate, managing the interpreter's roles become even more complex when guidelines have not been established through an effective pre-session or mini-contract involving both the provider and the patient. CERP in the pre-session. In the belief that an ounce of prevention is better than a pound of cure, we have this simple acronym, CERP, C-E-R-P, that helps us and serves as a checklist in the pre-session. CERP is designed to use prior to every medical interpreting session and stands for confidentiality, everything will be interpreted, rhythm, and person. Confidentiality. The interpreter explains to the patient that the provider that all the information that is shared during the session will stay among the parties at the session. A session starts with the first contact between the interpreter and the patient. Often, this happens in the waiting room or a clinic of a hospital. Everything you say will be interpreted. E. Everything shared in the waiting room, in the session, and after the session will be interpreted. Interpreters are not allowed to keep secrets from patients or providers. Rhythm. Interpreter may manage the rhythm of the session. The rhythm of a session is crucial to slow down or to pace their speech. During the pre-session, the interpreter may negotiate the use of acceptable hand signals to indicate when either party needs to slow down. P, the grammatical person, the first person. The interpreter will be using the first person whenever they are interpreting other people's words. But they will use the third person when they are referring to themselves, saying the interpreter XYZ. Therefore, when the patient or the provider says, I have to do something, the interpreter says, I have to do something in the first person. But if the interpreter needs to intervene as a clarifier, then the interpreter would say, the interpreter needs clarification. And in that way, the interpreter specifies the person for whom the words that are being said are being attributed to. CERP only works if all the parties involved understand its purpose. The interpreter needs to include both the patient and the provider in the explanation of CERP, and does so by holding the pre-session with the patient while in the waiting room and reviewing it with the provider when they join the session. But is the pre-session really all that important? How does the interpreter benefit from initiating such a discussion? What could happen if the pre-session is not held? Consider the following example. The interpreter as a conduit. A young Muslim woman goes to her first medical appointment in the US. The male provider begins to inquire about her sexual history. Feeling insulted, the patient abruptly leaves the room. The interpreter follows the patient and tries to persuade her to return to the session. Later, the interpreter expresses her apologies to the provider for the patient's actions. In this situation, the interpreter initially functioned as a conduit by faithfully translating all the provider's inquiries. This backfired when the patient felt that her dignity and honor were being compromised. After realizing that the session had failed, the interpreter experienced feelings of shame. This sense of shame then prompted her to apologize to the provider. The ethical dilemma here is whether the interpreter should have made the provider aware of the potential for a cultural misunderstanding before the session began. This question arises because, due to a cultural gap that was not addressed, the patient who had previously sought medical assistance is now likely to reject it. As we know, one dissatisfied patient can lead to several others as news of this distressing incident spreads among family, friends, and other members of the community. Another ethical concern is the sudden termination of the session, where the patient leaves and the interpreter follows her to persuade the patient to return to the session. What was the provider's role in this interaction, and is it truly significant? If a pre-session had been conducted in this instance, the interpreter would likely have equipped the provider with the cultural insights needed to handle a potentially volatile situation. If the interpreter had recognized that a young, unmarried Muslim female might feel uneasy responding to a male provider's inquiries about sexual activity, it would have been beneficial for her to communicate that information to the provider during the pre-session, before the interpreter began. This approach aligns with Section B2 of the standards, which indicates that a professional interpreter's obligation includes sharing relevant cultural information that could assist in clarifying the issue. The interpreter should introduce any cultural guidance with a respectful statement such as, although this may not apply to this specific situation, in my experience, this ... response is typical among members of ... community. If a pre-session was conducted and the provider still deemed questions regarding sexual activity essential for effective healthcare delivery, then the provider might recognize the intention behind the question and permit the patient to respond in an alternative manner. In this scenario, the interpreter could function as a cultural broker by familiarizing the provider with an explanatory model. While a provider may prefer a Western-style direct approach to questioning, they might first seek the patient's consent to use this method. All these elements could be discussed and negotiated during a pre-session between the interpreter and the provider. When does a session start? When does a session end? Interpreters, despite their commitment to ethical practices, frequently find the concept of patient confidentiality to be confusing. It is generally accepted that all information communicated during the triadic encounter should be interpreted accurately and fully for all parties involved. In the triadic encounter, privacy does not exist. However, the standards provide excellent guidelines for conduct within the traditional interpreting session, patient, provider, interpreter. They lack clarity, however, regarding unsolicited information that patients share outside of this context, which forces the interpreter to rely on their discretion in such situations. Although there are differing opinions about the official start of a session, it is common for patients to begin discussing matters exclusively for their provider while in the waiting area. simply because they are pleased to see an interpreter. Interpreters typically welcome patients in a friendly way. This can significantly ease a patient's apprehension regarding future medical sessions and communication. However, the patient often begins to speak freely, and the interpreter, out of courtesy, becomes a passive listener. While the interpreter is aware of the importance of not asking personal questions, even the simple act of listening can give the patient misleading impressions. Soon, the initial warm greeting may lead to the patient revealing sensitive medical details, followed by a request, "Please don't share this with the doctor." This situation can be quite uncomfortable for an interpreter. Nevertheless, if a patient is informed that the interpreting session commences with the first greeting in the waiting room and that any information shared from that moment on will be interpreted, they are less inclined to disclose secret information or bring specific medical concerns to the interpreter's attention. Interpreters frequently engage with patients who may not fully trust the medical expertise of their providers. In a manner that resembles a professional conspiracy, interpreters are often subtly invited to participate in a trust-building exercise. The following example demonstrates a typical situation encountered with substance abusers who test both interpreters and providers by divulging unsolicited information outside the triadic encounter. An older Portuguese gentleman visits his primary care physician and is advised that he must quit smoking if he wishes to improve his health. During a subsequent visit, the patient informs the healthcare provider that he has stopped smoking. The physician beams and congratulates the patient and tells him that his lungs are now clear. After their interaction, as the interpreter accompanies the patient to arrange a follow-up visit, the patient remarks on how American doctors are overly easily satisfied. In truth, he adds, "I still smoke, just as much as I did before." The interpreter grins and continues to organize a follow-up appointment at the reception desk. In the situation described, the patient communicated details to the interpreter while walking from the examination room to the front desk. The patient's appointment with the healthcare provider had concluded. Consequently, the interpreter might mistakenly think that they are not obligated to keep that information confidential. It's not uncommon for interpreters to state, "As long as the issue isn't life-threatening, I don't have to report it." In reality, some interpreters may refer to the standards as justification for their silence. Section C1 specifies that a medical interpreter who is aware of information related to suicidal or homicidal intentions, child abuse, or domestic violence must fulfill their duty to convey such information in accordance with institutional guidelines, ethical codes, and legal requirements. It may seem, therefore, that anything less severe than a life-threatening situation is insignificant. Still, is it truly ethical to withhold any information? We now ask, if every aspect of a session requires interpretation, when does the session actually end? Should the responsibility of deciding whether to disclose unsolicited post-triadic communication fall to an interpreter who lacks the necessary training to manage that information? Who ought to determine if the particular information is insignificant enough to share? Once more, a thorough pre-session will establish clarity regarding information sharing expectations prior to, during, and following the triadic encounter. The patient will understand that a session starts with the initial contact between the interpreter and the patient and finishes with the final farewell. Discussions in the waiting areas, exiting conversations, and all exchanges of medical information with lab personnel, chats, x-ray technicians, and nuances shared in hallways or elevators must be communicated to the provider. By clarifying what patients can anticipate from the interpreter, secrets will remain confidential, and the dynamics of the trust will not turn to an uncomfortable situation. Various interpreters have indicated a desire to guide patients in comprehending the American medical system. They contend that acting as a cultural mediator with the healthcare provider equates to being a provider advocate, and consequently, it also falls within the responsibilities to serve as patient advocates. A question arises: should an interpreter represent a patient independently of the provider's involvement? Before responding, consider the following scenarios. A young Latino man, recently diagnosed with AIDS, finds himself in the emergency room. His interpreter encourages him to inform the emergency room physician about his recent thrush case, as it might lead to an additional diagnosis. After all, the interpreter mentions that he has observed 3 similar cases in the past 2 weeks. The patient silently agrees. The interpreter takes pride in his guidance. He might be helping to save a life. A seasoned Portuguese-speaking interpreter advises patients that in the United States, doctors tend to be too busy to listen to lengthy narratives. She urges them to respond with yes or no to questions posed and to steer clear of discussing details that aren't directly pertinent to the inquiries. Some of these patients have expressed discomfort to subsequent interpreters, stating that this interpreter made them feel uneasy. A Haitian Jehovah's Witness arrives at an emergency room after a bad car crash, bleeding profusely. A blood transfusion is recommended. The patient refuses the transfusion, and the interpreter, familiar with the patient's beliefs, attempts to talk him into accepting the recommended treatment. In the previously mentioned situations, the interpreters ventured beyond the confines of their profession and for a brief moment took on the role of medical providers. By engaging in cultural coaching with patients without the presence and guidance of a provider, they risk creating an imbalance of power and potentially damaging trust within the triadic relationship. Do interpreters truly have power over patients? For the patient, the interpreter represents someone who speaks their language, often shares the same cultural background, and may even exhibit similar physical characteristics. The interpreter resembles me, the patient thinks. The interpreter is my ally. While patients might initially appreciate the idea of having a friend or supporter during the interaction, this can lead to confusion and anxiety. It falls upon the interpreter to navigate the distribution of power within a medical encounter. In the aforementioned scenarios, the interpreter would have been wise to conduct a pre-session with the provider, or at the very least, have a private conversation with the provider to address cultural and/or religious matters that could affect the encounter. The provider could then proactively discuss these issues with the patient. Ultimately, the aim of an interpreting session is for the patient and the provider to establish a therapeutic alliance. a significant part of the healing process relies on the patient's trust in the provider. In conclusion, until recently, the pre-session was regarded merely as a means to gauge the patient's overall linguistic register and perhaps gain a general insight into the potential clinical path for the provider. While this perspective is not incorrect, it does not fully harness the capabilities of a pre-session and leaves each interpreter to determine what information shared outside the triadic encounter is clinically relevant and how much should be relayed to the provider. This is why interpreters are advised to restrict waiting room discussions with patients to very safe, brief topics and to use most of the time before the triadic encounters to tactfully clarify CERP and its connection to the role of the medical interpreter. By doing this, the interpreter effectively sets the tone before a session, almost eliminating the risk of role confusion and misplaced loyalties during the medical encounter. Some interpreters find it simpler to start a pre-session with patients rather than with providers. This might be because many providers often jump straight into the interview process without introducing themselves or acknowledging the interpreter's presence. You, as the interpreter, collaborate with providers who may not understand the pre-session concept. Take the opportunity to briefly introduce CERP. Certain interpreters have discovered that interpreting the provider's initial comment and then immediately following it with, "Excuse me, I did not get a chance to introduce myself," can be effective. The interpreter can then briefly introduce themselves and explain the concepts of CERP, which should only take about a minute. Once all the parties involved understand the interpreter's role, and the interpreter can now focus on the session's contents, ensuring accuracy and completeness. However, it is clear that explaining CERP in the pre-session establishes a strong foundation for effective interpreting performance.